Our next speaker is Dr. Suzanne Adil. She will be talking about PET imaging of lung cancer. What does it add?
Good morning, dear professors and colleagues. The aim of this talk is to know why FDG PET imaging is an integral part in management of lung cancer patients, knowing its strengths and limitations, and recent advances in PET imaging. As we know, the incidence of lung cancer has rapidly increased since the beginning of the 20th century and currently represent the main cause of cancer-related mortality worldwide. And according to WHO classification, about 10 to 15% are small cell lung cancer, while 85 to 90% are non-small cell lung cancer, including adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Assessment of patients with suspected lung cancer has done routinely by morphologic imaging with just CT, but with emergence of combined PET-CT imaging, it greatly aided the investigation of lung cancer, lead to marked improvement in developments in its management. FDG PET-CT is considerable the state-of-art imaging tool that combines both the metabolic information from the anatomic CT images and the metabolic information from the PET images, and this is an integral part in diagnosis, staging, and treatment, and implemented in various international guidelines for evaluation of lung cancer patients. PET allows visualization and quantification of tumoral features at a molecular level, such as tumor metabolism or receptor expression. These are some quantitative parameters used during interpretation, which are SUV, MTV, and TLG. PET-CT has a major role in lung cancer staging, radiotherapy planning, therapy response evaluation, prognostication, monitoring of recurrence or restaging, and detection of another primary malignancy. Correct staging of lung cancer is very important because treatment and prognosis differ significantly according to the stage, and many studies reveal that PET-CT is highly accurate for TNM staging and identifying unsuspected metastases. And based on the result of a prospective multi-center trial, FDG PET-CT is changing the management strategies in approximately 72% of cancer cases. PET-CT is very accurate in detecting the tumor size and location. As shown in this case, this old female presented with left-sided pleural effusion and multiple bilateral pulmonary nodules, and referred for further assessment by PET-CT that revealed an ill-defined hypermetabolic soft tissue mass lesion within the collapsed left lung lower lobar parenchyma, and also revealed hypermetabolic small mediastinal lymph nodes. Another case revealed how PET-CT can differentiate the primary malignant neoplasia, which is intensely avid for FDG, from the surrounding less avid atelectasis. Another case with large right lung mass obstructing the right lung upper lobar bronchus, and it is well differentiated from the distally related atelectasis and associated with hypermetabolic mediastinal lymph nodes. A similar case. So FDG PET-CT is superior to CT in differentiation between the tumor and the obstructive, post-obstructive atelectasis, which is very important for accurate local disease staging, percutaneous biopsy guiding, radiation therapy planning, and assessment of treatment response. However, false positive results may be found with inflammation and infection, and false negative results may be found with small nodules hypocellular tumors as mucinous adenocarcinomas, minimally invasive adenocarcinomas and low-grade malignancies, and in carcinoid tumor, which is one of the neuroendocrine tumors that is characterized by overexpression of somatostatin receptors. So it can be imaged by another specific radiotracer combined with somatostatin analog ligand, which is dotatate peptide. As shown in this case, this patient had right pulmonary mass and histopathologically proven to be a neuroendocrine tumor. The whole body gallium dotatate PET-CT revealed a right lung mass, parahilar, that is intensely avid for dotatate, and this patient coming for follow-up after treatment, and the mass shows marked regression in size with no any dotatate avidity denoting necrosis. PET-CT also has high sensitivity and specificity for detecting mediastinal nodal deposits, even small-sized lymph nodes, as shown in this case, with hypermetabolic right lung mass and small mediastinal lymph nodes that are intensely avid on FDG, PET-CT denoting nodal deposits. Also, false negative results can be seen with low-grade malignancy, and false positive results can be seen with granulomatous infection as TB or sarcoidosis. Regarding M staging, PET-CT also has high sensitivity and specificity in detecting extrathoracic metastases that are commonly seen in brain, liver, bone, adrenal glands, and abdominal lymph nodes. This is a case with right lung cancer associated with active pulmonary, nodal, hepatic, as well as osseous deposit that is not appreciated in CT images alone. And this is one of the advantages of PET-CT that can detect the marrow-based deposits not associated with sclerotic or lytic changes on corresponding CT images, and can be missed when reviewing the CT images alone. False positive results can be seen with adrenal hyperplasia or adrenal adenoma, and false negative results may be seen in small brain deposits that can be not detected in CT images. Also, their activity can be masked by the intense brain parenchymal FDG avidity on PET images. Also, ability of PET-CT to detect with high accuracy the borders of the primary malignant neoplasia help in radiotherapy planning and preventing mistargeting and unnecessary irradiation to adjacent structures. The metabolic changes of the tumor and its metastatic deposits usually precede the morphologic changes, and this facilitates the differentiation between responders and non-responders, and distinguishing the necrotic or fibrotic lesions from the residual tumoral tissue. Subsequently, the tumor can be adjusted on an individual basis. This is an example of old male presented with metastatic left lung cancer to right adrenal gland. And after treatment, the patient come with almost stationary size of the primary neoplasia as well as its right adrenal deposit. Yet on PET images, there is significant reduction in metabolic activity in both the primary as well as the metastatic deposit. So this is considered a partial metabolic response, not stationary disease. Another case with non-small cell left lung cancer associated with hypermetabolic left hilar and subcarinal nodal deposit. And after treatment, there is subtle reduction in size, yet with almost complete resolution of the previously detected FDG avidity. So this case is considered a complete metabolic response rather than partial response. Usually, pre-treatment SUV max is associated with poor prognosis, but post-treatment high SUV max is more associated with poor prognosis, and recently other indices as MTV and TLG have more prognostic implications than SUV. Also, high SUV max is associated with aggressive tumors, as in this case with moderately differentiated invasive adenocarcinoma showing high FTG avidity, in contrast to the other adenocarcinoma in situ and minimally invasive adenocarcinoma that show low-grade FTG uptake on corresponding PET images. Usually, non-small cell lung cancer have high recurrence rate even after curative treatment, and PET-CT play a major role in differentiation of post-therapeutic changes and fibrosis from residual or recurrent neoplasia. Also has high accuracy in detecting distal recurrence, as shown in this case with non-small cell lung cancer underwent right lung lower lobectomy, and after 6 months coming for follow-up, there is intensely avid soft tissue thickening related to the surgical stump with hypermetabolic pleural deposits that are may pass unnoticed on CT images alone. Also, the PET detect in FTG avid hepatic and osseous deposits. In about 3 to 4% of patients coming with lung cancer, PET-CT may detect other areas of increased FTG avidity, and the most common sites of the second neoplasia may be seen in breast, colon, thyroid, and prostate and ovaries. This is an example of left lung adenocarcinoma with high FTG avidity. Yet another small speculated left breast mass lesion was found, and it was histopathologically proven to be invasive adenocarcinoma. Invasive ductal carcinoma. Another case with hypermetabolic right lung mass with other hypermetabolic pancreatic tail mass proved to be malignant, other primary. Another patient with hypermetabolic right lung mass with other ill-defined hypermetabolic right parotid lesion proved to be malignant primary neoplasia. Recently, PET instrumentation has undergone a steady evolution in software and hardware technologies, improving various aspects of imaging, which significantly improve overall image quality and resolution. And among these development is the introduction of total body PET, which is a recent technical development regarding PET scanners with long axial field of view, covering a majority of the patient body, surrounded with more detectors in axial direction with higher sensitivity, lead to reduction of the total acquisition time and those requirements. The first total body PET scanners were combined with CT as high sensitivity of these new PET designs will lead to PET acquisition time close to the speed of CT acquisition, yet it couldn't be applied with MRI as the acquisition of total body MRI would be much slower than PET acquisition. Regarding PET MRI imaging of lung cancer, it has higher morphologic imaging and low radiation exposure. It has superior detectability of pleural mediastinal involvement and high sensitivity for detecting brain, hepatic, and osseous deposits. Yet both modalities have comparable therapeutic decisions. And among the advantages of PET MRI is not widely available, very expensive, longer acquisition time, and low sensitivity for detecting small pulmonary nodules. There are many tumor characteristics that can be targeted and visualized by PET imaging rather than tumor metabolism, as tissue hypoxia, angiogenesis, amino acid metabolism, and choline metabolism. And these newly developed tracers broaden the applications and accuracy of this imaging method, and facilitating formulation of individualized treatment strategies. To sum up, the use of PET-CT has become a reliable tool that can complement and sometimes take the place of conventional imaging modalities. In radiological assessment of lung cancer, FTG is a standard tool for management patient of lung cancer, including diagnosis, initial staging, therapy planning, and early treatment response with restaging and prognosis. Radiologists should be aware with the pitfalls that may be encountered during their interpretation, and there is a steady evolution in PET software and hardware technologies, with the introduction of many novel radiopharmaceutical that improve various aspects of PET imaging. Thank you.
Thank you, Dr. Suzanne, for the very informative lecture. And it is a great pleasure for me